Morning. Good morning to all of you. I am Maria Grazia Dente. I'm calling from Istituto Superiore di Sanità in Rome, Italy, and I'm here with my two colleagues, Silvia Deklic and Maria Elena Tosti, to introduce and moderate the workshop of that will be the first one of a series of webinars aimed to address actions taken during this COVID pandemic. Today, we will address the problem of empowering and protecting the health workers, those that are really on the front line in this epidemic. I would like really to thank all the participants, all the speakers that have accepted to take part in this workshop, even if they are all very busy with this pandemic in their countries and with all other matters. And I would like also to really thank those that will contribute during the discussion, and also the experts that here at ISS, like Dr. Mazzacara, or at Istituto Carlos III, the expert Martinez, Vadillo, and Carlo Portero will help us to approach, to address the issue of this workshop. Now I will rapidly go through the agenda of the meeting. I will try to share my presentation. I hope that you can see it. So we decide to, as first workshop, to approach the problem of protecting our staff. We know, and was stressed also by WHO in Nigeria during this day, how is really important for the safety of the patient to take care of the safety of the health workers. So we decide to, sorry, I cannot go ahead with my presentation. Hiro, can you help me in some way?
You just need to move the buttons of the presentation, Maria Grazia.
Yes, I moved, actually. Do you want me to go out and try again?
Yeah, maybe if you go outside the full screen mode and then go back again. Yes.
Perfect. Okay. And today with this workshop, we have two main objectives. The first one is, of course, to share all the aspects related to the empowering personal protection and support for the healthcare workers. The other one is to provide some feedback on a distance learning module on novel coronavirus health emergency, preparedness and response, that we adapt, we prepare here at ISS in the framework on MediLabSecure to help in this specific moment of emergency the health workers to improve their capacities with an online learning module. We will see after. And of course, we would like to have your feedback in order to improve these training materials. Okay, the day, we have 2 hours to stay together. We really ask you, especially the presenters, but even those that will contribute during the discussion, to be really brief. We would like really to have space for all the presentations and for all the contributions that may raise. We have one part that will start in short and is focused on a keynote presentation delivered by the Director of National CDC of Nigeria. Then, as I said, we will focus on the activities that have been done by ISS and Institut Pasteur in terms of support to health workers' activities in the COVID emergency. And then we will have a second part that is dedicated to know what the countries are doing to protect their health workers. So we have different countries, and during the discussion, we will have contributors on this matter. We will close the meeting telling you what we have planned to do in the next months. So I am happy now to give the floor to the 2, let's say, networks that decide to organize this event, MediLabSecure and MediPIET. They will tell you in short what are doing, and I will call MediLabSecure Vanessa Lagal from Institut Pasteur, that is the institution in charge for the coordination of MediLabSecure Network. Please, Vanessa, really thank you for being very brief in your presentation. Thank you very much. The floor is to Vanessa.
Thank you very much, Maria Grazia. Can you hear me well? Yes. Okay, so first of all, good morning and good afternoon to everyone. It's a real pleasure to be online with you today. So as Maria Grazia said, I'm going to briefly give you the main lines of the MediLabSecure project. So the project is funded by the European Union under the umbrella of the Chemical, Biological, Radiological, Nuclear Risk Mitigation Center of Excellence Initiative launched 10 years ago. And so as such, the project participates in promoting the health security, stability, and peace by addressing the biological and biosafety related risks at national and regional level. The specific objectives of the project, the specific objective of the project is to prevent the biological threat, and more specifically the viral vector-borne disease, by reinforcing an international network of laboratories and critical institutions. It targets 22 EU neighboring countries around the Mediterranean and Sahel region. So to meet its objective, the project rotates around 2 main axes of action. On one hand, institutional networking, on the other hand, capacity building. And more importantly, the core of the project is the advocacy for the adoption of the one approach. The capacity building action address the enhancing of laboratory preparedness and capacity, notably the strengthening of arbovirus diagnostic capacity and the strengthening of surveillance and control of their vector. The capacity building action also address the improvement of, I would say, standard methods of surveillance towards integrated surveillance, risk assessment, and early warning. So the project is coordinated by the actor, and the actions are jointly implemented by 5 European partners, each responsible for a work package dedicated to one sector. So we have the human virology work package, the animal biology work package, the medical oncology. We have the work package dedicated to public health and veterinary services coordinated by the Instituto Superior de Sanidad, the co-organizer of the workshop today, and we have a last work package dedicated to early warning and briefly, what I wanted to say, as I already mentioned at the very beginning of my talk, the project aims at strengthening the preparedness and response capacity to emerging viruses. And so as such, since the beginning of the COVID-19 period, the project could be mobilized to provide support in SARS-CoV-2 diagnostic capacities to national and specific WHO laboratories, and also to provide support in strengthening surveillance and protection capacity. And related to this next subject, as Maria Grazia already mentioned, 2 activities have been implemented in the framework of the project, and these 2 activities will be further presented during the workshop. If you need or you want more information about the project, the activities implemented, the COVID-19 activities implemented, I kindly invite you to go on my website or just please feel free to email me. I'm going to stop there. I hope I stick to the time, and I'm going to wish to all a very pleasant workshop full of fruitful information and discussion. Thank you to everyone, and enjoy the workshop.
Thank you, Vanessa.
Yeah.
Thank you very much. And so now I think that I can give the floor to Isabelle Noguer, the scientific leader of MediPIET, which will tell us something about MediPIET and how what they are doing in this specific COVID emergency. Welcome, Isabelle. The floor is yours.
Thank you very much, Maria Grazia. I welcome to all participants, and this is not the first time MediLab and MediPIET join an initiative, and COVID-19 give us an excellent framework to exchange views and knowledge. I briefly introduce MediPIET, which is European Union DEFCO funded project in its 3rd phase. MediPIET is under the Instrument of Stability and Peace and linked to the CBRN Center of Excellence. MediPIET is focused on enhancing health security in the Mediterranean and Black Sea countries by supporting capacity building for prevention and control of biological, chemical, man-made or natural health threats. It is conducted under a consortium between the National Public Health Institute, Carlos III in Madrid, a health foundation led by the Ministry of Health, and it is under the leadership of the European Center for Disease Control and Prevention. MediPIET main goal, the MediPIET main goal is to perform an advanced FTP for the Mediterranean and Black Sea countries. The MediPIET 3rd cohort will be graduated by 2021. We have 15 fellows. All fellows, supervisors, and the MediPIET national focal points are really, really involved in the COVID response. For this reason, MediPIET has developed different resources, new resources, like a COVID resource center on its MediPIET webpage, and MediPIET webinars that will resume in October 2020. We count on all of you, like in previous version of the webinars last summer. I would like to be brief, so we hope from the MediPIET team these joint workshops focus on a change of experiences between disciplines, between countries and regions, to be the kickoff initiative for the coming MediPIET webinars next month. So where the main focus also will be the change of experiences and lessons learned from the pandemic. So we invite you, all of you, to enjoy and participate actively in this workshop. Thank you very much, and have a nice workshop.
Thank you, Isabel. Thank you very much. So I hope during the course of the workshop, there will be really the way to appreciate what networks can do together, what these countries are able to do in terms of preparedness, in terms of sharing their lessons learned to the benefit of others that are really in emergency situation like this COVID-19 epidemic. So I'm now going to present Dr. Tsikwe Ikewazu. He is the director of the National CDC in Nigeria, and he is going to present his keynote that will concentrate on the COVID response in Nigeria, putting health security on the agenda and keeping it there. We are really grateful to have you here with us. If possible, I would suggest to give to your presentation 15 minutes and to allow to have 5 minutes to possible questions from the audience. Thank you very much. Dr. Tsikwe, the floor is yours.
So thank you very much, colleagues, and thank you for inviting me to this event today. I consider myself part of the more global field epidemiology family. I started my professional life in public health at the Robert Koch Institute in Germany, and then I got onto the European program for intervention epidemiology training and moved. That took me to the UK, where I spent 10 years working. And within the Health Protection Agency, I did the MediPIET program and then the public health specialization before moving to South Africa, where I worked for 5 years at the National Public Health Institute in South Africa, the National Institute for Communicable Diseases, before moving back to Nigeria to lead the Nigeria Center for Disease Control. So the 22 years of work in public health has all been within National Public Health Institutes. And it's on that basis that I wish to share a few thoughts with you this morning. I'm very grateful for all of you for inviting me. So I will now try to share my screen. I hope I'm allowed to do so.
Yes, go ahead.
Okay. Is it showing now?
Yes,
we can see it.
Okay, fantastic. So I'll reflect a little bit on the COVID response in Nigeria and how important it is for health security. So firstly, I know we have a fairly diverse audience, some context about Nigeria. It's the most populous country in Africa. We have a population of about 200 million people. It is a federal republic, and this is very important for health security, for us to remember that countries that are federations are unique in how they organize themselves. So we have fairly autonomous states, 36 of them, and the Federal Capital Territory. So this is important in terms of understanding the opportunities and challenges of our society. The budgetary allocation to health is not as high as we would like it to be. About 5% of the national budget goes to health. We have a life expectancy that we are not completely proud of just over 50 years. In the last JEE score, we scored 46, but we are very strict with ourselves in that JEE. So, but that's really where we are. And we've had several recent outbreaks from Lassa, the Ebola outbreak in West Africa that affected Nigeria, not as badly as Guinea, Liberia, and Sierra Leone, but we do have our fair share of infectious diseases because, high population in the tropics, high population density, and very humid conditions and warm temperatures. So very ideal situation for infectious diseases to thrive, actually. So, over the past few years, we had the Ebola outbreak now on slide 3 in 2014. In 2016, we saw the re-emergence of polio. We were very close to elimination, which would have led to elimination in Africa. But that did not happen. We found 5 new cases, but there was a very strong and robust response to that, and which has led in the last few months for polio, now at least the wild polio virus being eliminated from Africa. So we've achieved that milestone. We've had a large outbreak of MENC, meningococcal disease in 2017, and we've seen the re-emergence of monkeypox, which then spread to other countries as well, and several consistent outbreaks of Lassa. So this is our reality, but what that has also led us to is a workforce that is used to and has had significant experience in dealing with the emergence of infectious diseases and infectious disease outbreaks. So a little bit about the Nigeria Center for Disease Control. It's a fairly new organization. It really emerged after the Ebola outbreak, and the country realized that it's important to have a national public health institute with the mandate focused on health protection and health security. And actually, the legal mandate for entities was only given in 2018. So from 14 to 18, there was a process of setting up, but now it is a legal parastatal within the Federal Ministry of Health, but with some level of autonomy, with a focus and a mandate around health security. It's a legal mandate. So our mandate is to prevent, detect, and control the spread of communicable diseases. We coordinate the surveillance systems in the country for infectious diseases. We support the states. So this is very important. Support the states, the federal states in responding to outbreaks, while we lead the response to national outbreaks. We maintain a network of public health labs. We coordinate and collate research for public health purposes, and we are leading the country's engagement with international health regulations. The pictures are 3 main campuses of in Lagos and Abuja. So a little bit about the COVID-19 situation in Nigeria. We have just under 60,000 confirmed cases and deaths, 1,100 deaths. We've just tested over 500,000 cases, tests. All of them are PCR tests. Our testing strategy has relied only on PCR up till now. We haven't included any antigen or antibody testing. We're in the process of now validating some of those kits, but these are all PCR tests. We have about 7,000 active cases across the country at the moment. The states most affected, for those that know Nigeria a little bit, have been Lagos, the most densely populated and the previous capital of Nigeria, the Federal Capital Territory, which is in the middle of the country, you can see on the map, some states in the southern part of the country, and Kano in the north, which is in fact the most popular state in northern Nigeria. In terms of tests done per week and confirmed cases per week at the yellow line. But probably the most important line in this is the dotted green line, which tells us the test positivity rate per week. So the proportion of all tests done that are positive for COVID. We can see that from the peak of the outbreak around weeks 26, 27 in Nigeria, we had positivity rates of over 20%. And now we're just over 5%, about 7% on average. And so it does show that there's been a decline in transmission in Nigeria. We hope that's a good thing, and we hope we can manage to prevent a resurgence of cases. In terms of how the response is structured, the Nigeria Center for Disease Control has managed the public health response. But because of the size of this outbreak, Mr. President instituted a presidential task force that included many other ministries, some of the security forces, education, ministries of interior, ministries of aviation. So we had a presidential task force recognizing that the response to this outbreak really required a multi-sectoral approach in order that all the sectors are working together to respond to this incredible outbreak in our lifetimes that really required all sectors of the economy to work together in order to drive that response. But the NCDC, which I led on the public health response. We set up an incident management structure. The pillars of the EOC are listed at the bottom, through which we coordinated the public health response. In terms of the multi-sectoral response, once we instituted a national lockdown in March, late March, like many other countries, initially, like many countries, when we're trying to figure out what was happening, we basically banned land travel, closed all our airports, instituted a curfew across the country from 8 p.m. to 6 a.m., reduced working hours, reduced staff occupancy in work at workplaces to 50%. We banned all entertainment venues, all religious gatherings, all schools, so just like everyone else. But we, at the same time, planned a phased reopening. So once we locked down, we started planning for a phased reopening, and we're now in almost the phase 3. We haven't completely reopened all the schools and entertainment locations, but we have almost reopened and tried to readdress responsibility from the state down to the individual and organizations to now take more responsibility for their own behavior and their implementation of non-pharmaceutical intervention. So we have moved from a state-enforced response to pushing a lot more responsibility to people and institutions and organizations to do what they need to do, because those measures are still important today as they were in March in terms of preventing transmission. So a few updates from Nigeria in terms of what we actually did to respond to this outbreak. Firstly, we started off, we were slowly moving to a web-based surveillance platform for all our surveillance activities. We hadn't quite completed this when the outbreak started, but we quickly expedited the rollout of SORMAS. SORMAS is a surveillance platform for both surveillance and outbreak response, contact tracing and all of that, all done within the same digital platform. So we use this platform to collect data from across the country, analyze it, and respond to the outbreak at state and national level. This is an example of a dashboard that we would use in our emergency operations center to analyze the data and plan the response, plan testing strategies, the deployment of supplies, visualization, and everything we need to do to respond to the outbreak was based on information that was gathered across the country. We have 36 plus 1 states, and below that we have what we call local government areas. So we have 774 local government areas. This would be districts generally, through which, those are the 3 levels of government in Nigeria, through which we plan the response. So managing surveillance through a digital platform, there would have been no other way we could have responded to this outbreak at a national level without a digital platform for surveillance. Probably our biggest challenge when we started was our lack of sufficient diagnostic capacity. So at the beginning of the outbreak, we had only 2 labs that were able to make this diagnosis, both in terms of the reagents, equipment, commodities in Lagos and Abuja. So over the last 7 months, we have pushed very hard. Now we have 71 laboratories that have been scaled up to be able to make this diagnosis independently across the country. So as we have increased testing capacities in the bigger labs, we've also repurposed labs like the Gene Expert infrastructure that was for TB and the Abbott and Cobas equipment for HIV, and converted them into testing for COVID-19 or for SARS-CoV-2, the virus that causes the disease. We've included the private sector slowly. We've managed the supply chain of reagents and commodities to make sure these labs keep working. So very complex supply chain deployment across the country. The third part of the response are managing emergency operation centers. So both at the national level and at the state level, we've managed the response through EOCs. EOCs meet at regular intervals. At the national level, we were meeting every single day at the peak of the outbreak. Now we still meet 2 times a week to go through all the activities that we are deploying to respond. Come together, the incident manager is well defined, the pillar leads are defined, everybody takes responsibility, reports back on the activities, and then new tasks are given to them. And this has really led to a very efficient management of the response at national and state levels, and as an opportunity to share information, assign tasks, give action points, and then deliver on things that have been done. Also, from the national level, what we've had to do is deploy rapid response teams to the states. So it's a big country. We have a lot of resources comparatively at the federal versus the state levels. So we've had to deploy teams to almost every state in Nigeria. And that was very challenging for our staff strength in NCDC. We have a staff strength of about 300 fixed staff and about another 100 ad hoc staff. At the time, we had teams deployed to every single state in the country. The other important part of a national public health response is the research function, especially with a new disease. You have to learn very quickly on what is going on and define a research agenda. So we put together a national COVID research consortium to coordinate research activities together with the Nigerian Institute for Medical Research. And we defined 8 technical areas of priority, and we're now conducting research into those 8 areas. A few days ago, we made our first big national publication on the outbreak so far. It was published in the journal Epidemiology and Infection. It's called The Descriptive Epidemiology of COVID-19 in Nigeria for the first 6 months of the year. So anyone that wants a little bit more information on transmission in Nigeria is welcome to look up that article. As you can see on the graph, paper was accepted on the 28th of August, so very recently published. The other key thing that we've learned, in many of our national public health institutes, we have a lot of epidemiologists, a lot of microbiologists, virologists. What we have very few of social scientists. So social science is becoming extremely important. And our experience, and I'm sure it's the same in many other countries, is you can tell people to wear masks, do social distancing, and when they don't do that, you really have to understand what drives behavior in the different countries. So we've increased our analysis of behaviors among people, analyze that and use that to try and define our messaging for people to work with us through regular polling, getting feedback, and tailoring the messages to address those specific issues.
Dr. Sikwe, try to
yes,
close really in a couple of minutes. Sorry for my really terrible role.
I'm getting to the end. These are some reflections on our response so far. For some reason, I can't move the slides. Okay. So firstly, some of the challenges. Like I said earlier, working in a federal government structure is quite challenging. There's the global shutdown in the supply chain architecture, so it wasn't easy getting supplies into the country. We had to respond to rumors in real time. Lots of rumors of it's a new disease. People didn't know what was going on. We've had to keep pushing people 8 months into the outbreak. People are getting tired, both in terms of the response and in their own measures. And like many countries, we had to balance the public health response to the economic realities of our country. 70% of the Nigerian economy is informal. So we just could not shut down the country for too long. And to end in terms of the future, we have defined opportunities and the need to invest in producing a lot of these equipment and reagents locally. It's the only way we can survive when there's a global shutdown. We need to keep focusing on building a new generation of public health professionals to support the future, invest in the development of labs and treatment centers, and really bringing together the various sectors of the economy that we need to respond to this outbreak, and make sure that we have the legislative backbone to do all of this. So in conclusion, really, my thesis that we cannot respond to outbreaks of this size. We cannot implement health security infrastructure and architecture if we don't have national public health institutes to do that. Ministries are not best suited to implement. The health security is about doing. And so we really need NPIs to implement a health security architecture. We need to work together across regions. Health security cannot be limited to one country. So we need to get ahead of the nationalism at the moment and build a multilateral response to health security. We need to collaborate more globally, regionally, and in our various regions. It's the only way we can survive to ensure, for COVID-19 at least, equitable access to vaccines and therapeutics. And finally, especially for countries like Nigeria and many other countries like yours, we all need to find the balance between economic realities and driving an efficient public health response. Sorry, I took a little bit more time. I was given 20 minutes in the beginning, so it was a little bit difficult to cut it down at the last minute, but it's been a real pleasure to share a few minutes with you this morning. Thank you very much.
Dr. Sikwe, was for us a pleasure, really. I mean, was congratulations, not only for the presentation, of course, but for all the capacity that you put in place in Nigeria to cope with this emergency. Of course, I would like to ask you many things, but let's give before the floor to the audience. Please, is there any questions or someone that want to contribute? I will give 5 minutes to the discussion. Please, I would call to help us Concha from MediPIET and Hiro still from MediPIET to help us in searching for possible questions or contribution. I am here in any case to follow.
Hello, thank you, Dr. Sikwe. This is Concha Martin from MediPIET. From the chat side, we just have greetings from Kabul, Afghanistan, and thanks for this informative presentation and for sharing your knowledge.
Thank you very much.
Thank you. I don't know if there is any hand raised, Ido?
No, there is no hand raised. So if somebody has any question, please unmute yourselves and just ask the question. Isabel Noguer. Yes, Isabel, please go ahead.
I have very much appreciated your presentation. We have very similar troubles with a decentralized country like Spain. I'm speaking from Carlos III in Spain, a very, very decentralized country. And I'm wondering, how do you deal with the inequalities in resources, capacity, decision-making, and effectiveness of different prevention measures that can be put in place in different regions? How do you manage all these questions? Thank you very much.
So thank you, Isabel. I think that's a very good question. You know, for us, this response has been an opportunity as well. Previously, you know, if I would have spoken to our political leadership about labs, surveillance, you know, nobody would have been that interested in the work that we do. But suddenly, when an infectious disease, a virus led to the shutdown of the economy in Nigeria, everybody became interested. Everybody now knows who the Nigeria Center for Disease Control is in Nigeria. What that also led was a few more resources that have come in to the organization, which we have now deployed to places where they're needed the most. So we have really proactively sought extra resources from our own government, from the corporate Nigeria, and pushed those resources to areas where they're needed the most. So it's not an exact science, because sometimes even the areas that need it the most don't want that support. So you have to really learn to keep negotiating with leaders at various levels. So there are a lot of soft skills required as well as the resources. So this has really been work in progress, but it means that it's not enough to have resources to do things. You really need to engage politically with political leadership at the sub-national level and convince them why it's in their best interest to build up these opportunities for their state. So a lot of soft skills required in moving forward, but there's no simple solution. But thank you very much. I think it'll be very interesting in the end, at some point at the end of this outbreak, to bring together countries like Spain, Germany, Nigeria, to have decentralized modes of government to think through how that affects the implementation of health security in our different countries.
Thank you very much.
Okay, Concha, if we have, a comment, very short comment, or something communicating in the chat, because otherwise in 1 minute we will go to the next session.
Not from the chat. I don't know if from the hands raised.
No, Katie Ginger is there. Yes, we have a question. Katie, you please go ahead.
Hello, everyone, and thank you for this presentation. Do you hear me?
Yes.
Okay. From your presentation, we found out that the country is quite big, and the amount of people, the population is 200 million, and the cases, what confirmed is about the 60,000. Yeah, 60,000. 60,000. 60,000, and okay, and the tested people are about the 500,000. What is your policy regarding the testing of the people? Because comparing with the total population and the activity cases also, as well as the tested people, are less than in reality should be. So could you explain the testing system and what policy you have in this regard?
Yeah. So thank you. Very important question. So firstly, just to be very open, in the beginning, we did have a lot of challenges around just having the capacity to test. So the lab infrastructure. So we've been building that up. The second thing is, who do we test? So we do definitely test people that fit the case definition. We don't generally test asymptomatic people unless there are contacts of cases or there's a clear reason, indication that they have had significant exposure. So if you're a family member of a confirmed case, for instance, but we generally don't test asymptomatic people. So we're trying to increase the number of people that we are testing. But like I said, right now, we do think our epidemic is in decline. Not only do we see a lower case positivity ratio, our hospitals are no longer full. So early in the outbreak, even if we were not finding all the cases, the severe cases will still come into hospital. And our hospital admission rates for people with COVID-like symptoms have also reduced. Our deaths have reduced. So there's something definitely that has led to the intensity of transmission not being as high in Nigeria and in many other African countries as we have seen in many other regions of the world. This is something we still have to understand fully. It might have something to do with the age structure of our population. It may have something to do with the fact that there are very few people living in institutional settings. So we don't really have elderly people's homes. People are mostly in the elderly live in the villages or homes of their families. So, it's a little bit of a different population dynamic in Nigeria. These are things we will have to study a little bit harder over time as this situation progresses. Thank you.
Thank you to you. I'm sorry because this is really an important discussion. I need to close this session. I would like to close with a message that is coming from Ethiopia, from the Ministry of Health, and they are saying, thank you very much, Dr. Tsikwe. That was a great and informative presentation. We have got much lessons to be taken to our contest. So closing with this, I would take also your recommendation. When this will be almost over, and I'm referring to the COVID-19 epidemic, really we hope to meet vis-a-vis at that time to share which were the main challenges for us and to see how we really could be ready in the real time next time. So thank you very much, really, Dr. Tsikwe. I'm sorry to close because many issues are raised, but we should go ahead. Thank you very much. Thank you.
Thank you.
So I'm trying to share what I would like to share with you. So I hope you can see. Very rapidly, I will try to share with you what we have done here in order to help staff at each level, I would say, those that are being involved in this emergency, to help them to reinforce their capacity. Briefly, we prepare a training module starting from an online training module that was prepared by our training service is here at Istituto Superiore di Sanità. You know that Italy really was one of the countries which has faced a very dramatic COVID emergency. So there was the need to support the health personnel, not only considering that they were very busy with a lot of emergency issues, but also that this emergency was quite new. So we were in need to update continuously the scientific evidence and the official source of information. So on the basis of this effort, we decide to modify, to adapt, integrate this module, translating it in English and French, in order with the aim to make it available also to other countries, not only for self-training, but also to be an instrument for trainers to organize training at country level. So this was a very rapid action, I would say, because we start in April to adapt this ISS Italian training, and we prepare really in 1 month an adapted training for all the countries that could have been interested in using it in English or French. Of course, this should be considered a process. We don't think that we can capacitate ourselves only with, a training, an online training, but we need also to meet, to revise what we are doing, to see if some information, some strategies should be updated or not, or modified. So for this, we consider it a process, and for this, we are here today with this virtual workshop. We hope to be able to have another workshop in the next year with lesson learned and recommendations to be provided still to address the issue of training and capacity building for health staff. In the case of ISS module, we use the approach of problem-based learning, that is a method, an approach student-centered. I will not go in detail because I hope that the head of the training center afterwards will help me in this. So this course is composed of 3 units. You can see the issue of the units in my screen, but of course the first unit will make the point on this emergency, will characterize the health emergency. Then there will be focus on surveillance, identification and management of suspected and confirmed cases, and then information for healthcare in order to prevent and protect also them, both at clinical and both in clinical and community settings. Each unit contains a pre-test, of course, to let's say, self-test your benefit, the benefit that you received from the unit, and then a problem is set, and the challenges is to solve this problem through the unit. Of course, you will find also supporting materials, reading materials, and 3 tutorials. So there will be, there are 3 PowerPoints for each unit, which try to cope with all the issues, all main and critical issues in the sector mentioned in the unit. So, so far, we have more than 230 subscriptions to the course, and I would say around 30 countries involved. As you can see, the majority of the subscribers are those that are applied to the French version. For sure, the motivation is due to the fact that around 100 of those 200 people are involved in the impact study on health workers that will be described soon after by Institute Pasteur. But still, there are other 100 participants that are asked for the French course. So we were discussing with our colleague at Pasteur Institute that most probably there was a gap in training materials available in French language. So probably there were a lot of course and modules available in English, but maybe a lack of in those produced in French. So, which is the situation now instead for those that are attending the trainings? So the around 100 participants that are attending the trainings without considering those that are involved in the impact study. Well, we have in blue, in light blue, those that have received the credentials to access the course, but still they have not started. So to be clear, they send their request of participation, they receive the credentials, but they have not started the course. And this is the weak point, at least so far. We interact of many of them, and we were informed that they have no time at the moment to follow the training. In yellow, those that instead access the course, they give us some information, but they do not proceed with the course. And finally, in red, those that have started, and almost some of them are finished also during these days. Here on your right, you can see the 32 people that instead ask for the training materials and access the course in order to use that materials to have residential course in their countries. So, of course, we adapt the course in many persons in order to have this ready in 1 month's time, and we are grateful to all the people that help us. And we are also grateful because while we were preparing this training, and now that we are monitoring the participation to the module, we understood that it's not so easy to prepare and to make a training module fruitful during emergency situation. But we are, in any case, we are happy because we have here with us some health personnel, health staff that succeed despite the emergency situation in finishing this course. And we would be grateful if they could share some aspects of this experience with us. If I don't know if it's connected, but I would be happy to have the feedback of Ani from the National CDC Center in Armenia. Ani Makuyan, are you here with us?
Yes, I'm with you. Thank you. It was very interesting and productive course for me. It covered many public health measures, for example, risk assessment, strategic preparedness, and response plan, surveillance, identification, and management of suspected and confirmed cases. The online learning platform was simple, and it offers access to updated content anytime. So we haven't any problem in finding time for our personal training. The course objectives were clear, and the content was consistent with the course objectives. Also, the educational method was very easy, and it was based on the problem-based learning.
Lo so, però io non posso avere accesso alle cose, hai capito?
Please, Maria Grazia, can you mute your microphone? Thank you.
Overall, like educational quality of the course was very good, and I think I can apply what I have learned in this course to my professional work. Thank you.
Thank you, Annie, and sorry for rushing a bit, but we would like to know if also Alina Druk from Moldova is with us, and if even without reply to each of the questions, but if Alina has some feedback for us to strengthen this course for the other participants that will be ready to start. Thank you, Alina. Are you with us?
Yes, of course. Do you hear me? Do you hear me?
Yes, very well.
So great. Hello to everyone. At the first, I want to say my congratulations for this really great job in this little time. It's a very comprehensive course with this module. And it was very easy to follow, very easy to enter in this course and to understand where these all steps, what I have to do. At the first, it's very much information, and then I opened the first module. It's really, I was a little bit scary because it's a huge number of pages. It was really impressive, and maybe like I don't know, like my opinion, maybe to have more, you know, like for each article or for each information presentation to have a part folder, not combine all this in only one PDF. And also I really enjoyed the test before and after. It's very interesting to see what you already know about this module, and after that you know in which part you have to dedicate more time and attention, and where is your lack in this topic.
Thank you. Sorry, we cannot go too much ahead.
Okay.
yes, because we want to know also the the impression of other participants, and we are a bit late. I would like to take advantage of Ani and Alina and now Reham, that I will call, to say that they are MediPIET fellows, so in the collaboration between these two networks is also valorized, synergized by this training, and their feedback on the training that was prepared in the framework of MediLabSecure. I would, if there is 1 minute, I hope I would see if Reham Kamel from Egypt, from the Ministry of Health and Population in Egypt, is with us, because she is a doctor that has participated to the training and download the material to prepare trainings in Egypt. So a very specific role for this module. Reham, are you with us?
Good afternoon, everyone.
Yes, the connection is very bad. Sorry, Reham. Sorry, we are sorry. We thank Dr. Reham. We hope that Dr. Rama, please close the connection because we cannot hear. Thank you, and sorry. We hope, sorry to give advice to Dr. Hannah to check her connection with, I don't know, with here or with someone, because she has a nice presentation soon after this session. So I will go ahead. I thank those that give us some feedback on the training. And I would like to give the floor, here I am, to the next speaker, that is Dr. Lazumar from Niger, and from the Medical Health Research Center in Niger. And she will tell us which is the study that they are carrying on, of course, with Pasteur coordination in the framework of MediLabSecure. And I really ask Dr. Lazumar to have maximum 10 minutes. I will call her in 8 minutes to remind the time. Dr. Lazumar, are you here with us? Okay, so let's hope to have this presentation at the end, maybe after the first session. So now we are going in the second part of the workshop. Of course, we will have divided this session into parts, because the first one will address specifically training measures adopted by the countries, and the second one, instead, other measures direct to the protection of the health workers. Protection and training and capacitation are the means that we have to reinforce the health workers. So in this first session, we will have 3 countries, Armenia, Egypt, and Senegal, that will say to us what they are doing in this field. So I will call now Lucine Paronian, she's from the National Center for Disease Control and Prevention in Armenia. I hope that Dr. Lucine is here with us.
Hello, everyone. Can you hear me?
Yes, very well. Welcome. Please, you have 7 minutes for your presentation. I will remind you the time in 6 minutes time. Welcome, Lucine. The floor is yours.
Okay, thank you, Maria Grazia. Nice to meet you.
Could you put in presentation mode?
Yes, sure. So, is it okay? I will let you know about COVID-19 preparedness and response, the case of Armenia. Armenia was one of the countries that was affected with COVID very dramatically. Our first case was in 1st of March, and until now we have almost 48,000 cases with about 1,000 deaths. Here you can see the daily new confirmed cases, and as you see, after decreasing our cases in July and first part of August, now again we have some increase of cases, unfortunately. During this period, country-level coordination, planning, and monitoring was done in 3 phases. I will not go very detailed. For the first phase, we had soft restrictions. For the second phase, we had strict restrictions, and after that, strict restrictions with localization. And during this period, intersectoral commission was established, leading by commandant office, and the Ministry of Health was leading national response to COVID-19, and National Center for Disease Control and Prevention was coordinating communications and international reporting, also surveillance. During this, now we are on a stage that state of emergency due to coronavirus pandemic operated for 6 months from March to September. Inclusive. After that, the Parliament introduced amendments to the package of relevant laws, and the Armenian government introduced quarantine across the country for a period of 4 months until the January of 2021. The quarantine implies a special regime to enter and exit into the country, the rules of self-isolation, as well as number of restrictions, including those related to social events, the educational processes, and economic activities. Individual protection measures must be applied all over the territory of Armenia, even now. As we have no many time, I will go at for case management, WHO treatment guideline translated, updated, and disseminated among the relevant health professionals. Physical infrastructures, improved hospital capacity through 10 repurposed hospitals designed for designated for treatment of COVID-19, with overall 10 hospitals with total 1,700 beds, 180 ICU beds. And workforce for case management was workforce of newly designated 10 hospitals, ICU specialists from other health facilities, repurposed to designed health facilities to treat COVID-19 patients. Also, extra health workers, volunteers with medical education, including nursing and medical students, retrained and repurposed for COVID-19. The National Institute of Health trained 1,782 health providers throughout the country to recognize and treat COVID-19 patients, including 40% of physicians, 60% of nurses, and other support staff. From them, 50% were from capital city and 85% were from regions. I will go to the trainings more. Every positive COVID-19 patient was hospitalized, those without symptoms placed in hotels with medical services. Also, PPE were available in all health facilities of the country, and government and humanitarian partners provided certain quantities of PPE, ventilators, and tests. National production of PPE organized, and national production of tests also now organized. National Institute of Health, given that the preparedness and knowledge are vital for addressing the global coronavirus pandemic, National Institute of Health, named after Abdelbekian, was organized a series of trainings, webinar sessions for the medical professionals. The main goal of the training and webinar sessions was to develop the capacity and knowledge of the medical specialists on novel coronavirus. Overall, NIH organized...
Lucine, you have 1 minute, sorry to be so...
Okay. 34 webinars with simultaneous translation into Armenian with various specialists from around the world. You can see here the countries, and almost 89% of trainings were conducted online and 11 were conducted offline. Approximately 3,500 health workers, 533 school nurses, and 600 kindergarten staff received COVID-19 infection prevention and control training. And about 2,000 doctors took part in training new coronavirus essentials for physicians, and 36 administrative staff workers also.
Okay, thank you, Lucinate. We will add some information during the discussion that
Yes.
I suggest to have at the end of these 3 presentations, because there could be many aspects that are cross-cutting the three countries that are being presented. So at this point, thank you very much, Lucine, and please stay with us for the discussion.
Yes, I'm here.
Thank you. I don't know, because now I would like to give the floor to Dr. Anna from Egypt, but I don't know if her connection is good, because before we had some problem. Lucine, switch off your microphone, please. Is Dr. Hannah with us? Okay, it seems that Dr. Anna will be contacted with another meeting, but she should close her microphone, otherwise I cannot go ahead with our partners in Senegal. I hope that Dr. Boli Diop, that is representing the Ministry of Health, and Dr. Barry from Pasteur Institute are online.
Okay, so you will give the floor to Senegal?
Yes. Good morning, Prof. I'm ready to give the floor to Senegal to have their view, and please remember that we have 7 minutes.
Okay, thank you very much. Boli to speak.
Thank you for the floor. For Senegal, Dr. Barry. Dr. Barry, you have the floor.
Est-ce que nous entendons là?
Oui, vas-y.
Hello, thank you very much, Dr. Boli. So, I'm Dr. Barry, I'm a medical epidemiologist. It's my pleasure to share with you some strategy implemented by Senegalese authority to tackle this COVID-19 outbreak in Senegal. So, in the introduction, so my presentation will cover these topics. You will see them on the explication. So, in Senegal, the National Epidemic Management Council delocalized the outbreak response according to the healthcare stratification in Senegal. And that means that in Senegal, we have the National Epidemic Management Council, which lead all activity in line of response to any epidemic in Senegal. So for this particular epidemic, so they try to build capacity on the regional and also on the departmental areas in line to put there the regional epidemic management council, and also at the departmental level, government try to activate the departmental epidemic management council that makes sure that there hope will cover and coordinate all activities at the regional slide. The National Epidemic Management Council makes sure that multi-sectorial approach was used in line of the coordination area at the highest level of the Ministry of Health and also other ministry involved in this response for this epidemic in Senegal. And also they put on one case management group that includes the National Infectious Disease Service Department. And also they give another activity to the infection prevention and control that was leading by the National Service of Hygiene in Senegal. And also they built another group which was entry point and laboratory surveillance in this particular group. So the IPD, Institute Pasteur of Dakar, involved in this group and made very big work in line to respond to this epidemic in Senegal. And also, you also have other groups such as community communication and engagement, and also the outbreak intervention teams that they build up around all the country at national, at regional, and also at departmental level. And also you have the another groups that cover all logistic mobilization and the resources. And this group will help all teams on the field to give them resources such as PPE and also mask, face, to make sure that teams have some tools so to make sure they have the opportunity to do their good job in the field. Slide. So in order to early detection and rapid management of cases in Senegal, the government put in place one cell alert, that means one alert group, which receive all information from all information from community people and also from patients who have some symptomatic symptoms, and also from entry point and from other health structure around all the Senegal. And those people, they give information according to one or two lines which were open to any people in Senegal, which can give them opportunity to get information and to give some quick management via from teams from the response team around the district and also around the departmental and the regional area. So here you can see some strategic training we made in Senegal. So at the first time, at the beginning, so the government, the Ministry of Health elaborates some standard operation procedure in line to the surveillance area and also for the early detection of cases, and also training on sampling and biomaterial transport, so for the conditionment and also the transport of any sample from any area in Senegal, and also for the prevention, some SOP for prevention and control of infection. And for the case management, we use most of the people from the infectious disease department to make training for all health workers around all the country, and also some SOP for information to inform people and also health workers. Slide. So that training strategy will building according to some stages. So you can see here at the beginning, so what we made is to targeting health care workers at risk. So that means you can get the team around the regional medical officer and also the team from the district medical officer in Dakar. We try to give them some training on this disease aspect of epidemiology and virological aspect of disease, COVID disease, and also how to translate information and how to give how to handle these forms for patients if patients have some symptoms, and also how to take this PPI and how to take sample, to condition sample, and also to transport sample from field to the laboratory. That was at the beginning at Pasteur Institute in Dakar. And also we want to make some training of...
Sorry, I do 1 minute remain.
Okay, so this is the last slide, I think. So we made also 3 days cascade training of all Senegalese health workers. So where we made the training of trainers, they go on the field and to train all the health workers at the field. So after that, in time of challenges, what we made is what we see is that we didn't have this continuous and rapid evolving situation, make sure that we cannot have enough time to make training for all health workers around the country. So that means after also the training, we didn't notice that there are lack of e-learning course monitoring service in remote area that will help people to know if they understand really what they made on the field. And also we did notice some necessity of experience of nasopharyngeal swab procedure. And also, we think that maybe we will have pragmatic and practical approaches rather than theory, because we noticed that on the field, when you made some training, a theoretical training at distance, when you arrive in the field, you can see practically they don't must have so many practical information. So that means, yeah. So that means that the ministry. Okay, so that means that we have on the next time to make sure that we can plan to make many practical training on the field more than theoretical training, because most of the health workers cannot understand very well at distance, the distance training they make. Thank you very much.
Thank you to you, Dr. Barry. It seems that you are very much in the issue. I mean, you were able to report to us what you were doing, but also challenging that are really shareable, and I mean, what we are also facing in many countries. So thank you very much, and please we stay with us for the discussion. At this point, we are having problems in connecting with our colleague from Egypt. So I would leave the floor to Dr. Lazumar, that I think is now connected and with us, to have her presentation. I'm really sorry to ask her to shrink a bit her presentation, because with this inconvenience we are a bit late. So Dr. Lazumar, you are welcome. The floor is yours. I will remind you when 1 minute is missing. Thank you. Dr. Lazumar? Okay, while we are waiting for Dr. Lazumar, I would like to ask Dr. Alfonso Mazzakar. I hope he is with us. Alfonso, are you with us?
Yes, I'm with you.
Okay, Alfonso, Dr. Mazzakar is the head of the training service here at ISS. So he is really the coordinator of all the training initiatives that are activated and produced here at ISS. I would ask him, Alfonso, you have seen the situation in Armenia and Senegal. What would you suggest? What could cope with this challenging in terms of training when you are in an emergency situation like this COVID-19? What COVID-19? So, how would you help the trainees to improve their competencies, which means, thank you, Dr. Mazzakar, only 3 minutes, please.
Thank you, Maria Grazia. Thank you to all of you for this opportunity. I work for the training office of the National Institute of Health of Italy that started to work in 2004 with distance learning. I know that I'm speaking in an environment and in a floor that is in changing. But anyway, our experience here started from 2004, but also if we have more than 15 years of experience, I can say that in the last 3 years, the mean of participants that used the e-learning courses was 40,000. Only this year, we were able to collect more than 400,000 of participants. It means that in a very few words, in Italy, so clearly in our environment, in this environment, we are trying to put a lot of efforts on the distance learning because it's one of the main issues able to share a common language among the health personnel, and also to share the main important procedures that needs to be implemented. Clearly, after the course, we try here in Italy to share other issues, other skills such as reports and more complex skills. But anyway, by using e-learning, we are trying to answer this pandemic in some way. Also because clearly there is not the possibility to be in contact with the other persons. Thank you. I try to be very short, and the experience here is the main important experience is this one. Try to use the e-learning as much as possible.
Thank you very much, Alfonso. Of course, it would be nice to discuss a lot on this, many articles, many debates are going on which is the best way to train people during emergency. I would leave, in any case, the floor to possible questions or requests of interventions. Concha, Iro, I would be glad if you can help me. Is there anyone that wants to contribute to this discussion on training?
Hello, from Concha speaking. From the chat, we don't have any question. What about the hands raised, Iro?
Sorry?
Iro? Do you see anyone with the hand?
Sorry, I was on mute. I don't see any hands right now, but I have a question regarding the training during emergencies. So we know how important it is to train people during emergencies, and especially for new novel diseases, emerging diseases that we don't know so much about, just like COVID. However, our experience from low-resource countries, even from high-resource countries, is that people are busy responding to the emergency and they don't have available time to participate in any kind of training or to the ones that they should be or they would like to. So my question is, how do we deal with the lack of time, and how do we protect some training time for the healthcare workers so then they can do their job more appropriately? Thank you.
I don't want to reply to this question. I'm only intervening because maybe if it's connected, the director of training, research and scientific consulting department in Libya, Dr. Fuzizia Salem Alghani, could help us. Is Dr. Fuzizia connected?
She is.
Can he say something on the strategy of training people in Libya? That is.
Okay, Assalamu alaikum. Good evening, everybody. Sorry for delay due to the power cut in Tripoli. It's the reason for coming late.
Welcome, welcome.
Hello.
We are happy to have you with us. Please,
thank you.
Try to reply to our challenging in the training.
Okay. In Libya, we have a staff working in PCR for detection or diagnosis for COVID-19. The lab of National Center of Animal Health now working with another lab for detection for COVID-19, and the sample which tested now in Libya, 5,000, maybe 40,068, all the sample. We have staff training for PCR, for ELISA. This is training of Libya, but I think I need advanced training for my staff.
Okay, so please, you are welcome also to send the names of people with the email address that are interested in having this training developed at ISS. I would like to add one thing that maybe was not underlined so far. The training that was developed here at ISS is, let's say, addressing a different type of background. I mean, it's not only for health staff with specific health background, but of course he can be, let's say, attended also by veterinary staff, by people that is working in the animal sectors, people that are working in the social sector, maybe at community level. So these, or people that is working at lab level. So please, I take advantage of the fact that Fulvia is asking us, but please be aware that the training is open at least until December, and we will be happy to follow also the staff that from very far intends to attend the training. They can access the platform the first time, but then they can download the materials. They don't need to be permanently connected to internet, and so is a module that could be used also at a very peripheral level. Thank you very much for your participation, and we need to go ahead with the second session. Now I kindly ask Dr. Fulvia to switch off the microphone and to stay with us for this second session.
Maria Grazia,
yes,
Maria Grazia, may
yes.
I interrupt you? Sorry. I was in contact with our colleagues from Egypt in order to solve the issue of the bad connection. They are proposing that another person, Dr. Hessa Magdi, does the presentation for Egypt, if that's okay with you.
Yes, if it's okay with all of us, I think. So it's okay. I really ask to take 6 minutes, not more, because we are very late and we need to move to the second session. So yes, I don't see the other doctor, but the floor is for her or him, and please go ahead. Thank you very much.
Okay, thank you, Iro, for giving me this chance. I'm sorry on behalf of Dr. Hannah for this connection problems. I will try to share my screen right now to have it in short. Okay, so I'd like to speak about the national COVID-19 training strategies and challenges in solution in Egypt. Egypt is here in the heart of the world, if nobody knows where Egypt is. Distribution of health level in Egypt, starting from the Ministry of Health as central level, with international, with sub-international or intermediate 27 health directorates, followed by 300 health districts. And these health districts is distributed to more than 6,000 primary health care units and more than 1,800 hospitals, chest hospital, fever hospital, general, central, educational, and the private sector hospitals. This is a Department of Epidemiology and Surveillance departments and units, including the FETP program and the coordination with the Egyptian Fellowship for Training for Epidemiology. This is a training process in Egypt, starting from the central level. The central trainers train central trainees, and both of them train the intermediate or health directorate level, and also train the peripheral level. Each level trains external non-Ministry of Health organizations at their own level. The timeline of training during COVID crisis, we start in January once the WHO declared that there is a public health international problem. We start to have all the information available to train our staff through the course and the period of this crisis on main 4 items or 4 methods for training: large group training, small group training, online training, and on-job training. If we see at April and May, after between the lockdown and the lifting restrictions and easing it, there were no large group training, and small group it was minimal at the beginning and the end. Only we rely on the online training method. The large group training targeting all or some governorates together, all or some districts in 1 or 2 neighbor governorates, most of hospitals of common activity like staff from fever hospitals, staff from chest, educational, general, some sentinel sites like sentinel hospitals with the same activity. The small group training usually for a certain group in the central level or through health directorate or health district for special reason. It's normally for a single issue or to TOT training. On-job training, it's like a field visit to the working place for a special group or special individuals in their hospitals and university surveillance units in universities, in lab or local laboratories. The training topics are locally developed under supervision of the General Department of Epidemiology and Surveillance concerning the epidemiological materials, and the scientific committee at the Ministry of Health for the clinical content, with reference for WHO, ECDC, and published paper and national guidelines. Topics for healthcare worker, professionals or clinicians, it includes hospital infection prevention and control, case management, classification, isolation, treatment, updated treatment protocol, COVID-19 case management under specific medical condition like COVID with diabetics, with hypertensive, with pregnancy, with children, also for critical care management protocol. Topics for public health professionals, including the normal outbreak investigations and control training, case notification and reporting, National Electronic Disease Surveillance System, which is the NEEDS electronic system for reporting COVID-19 for all communicable disease, especially COVID-19 cases. Also, we train them on the case definition, case contact tracing, home isolation, health quarantine, and normally it includes case studies, training on lab testing procedures and regulations, monitoring and evaluation measures inside and outside healthcare facilities. Topics for...
sorry, Dr. Esham, 1 minute.
Okay, I almost finished.
Thank you, thank you.
You are right. Topics at reopening, preparedness, if we have mass gathering, specific mass gathering, schools reopening, organization of the 27th Men's Handball World Championship. Some common subjects for all groups, including the updated definitions, epidemiology, and preventive measures for COVID. Challenges that we face as normal: epidemiological factors, increased transmission of COVID-19 and lack of knowledge, some critical or governmental regulations, including group meeting restrictions, lockdown, closure of hotels for accommodation, restrictive intergovernmental traveling, national or local work overload because of the increased work because of too many cases to be reported, infected healthcare worker and public health professionals with COVID-19, restriction of risk groups working like chronic cases, pregnant women, and so on. Some technical issues like we just faced: internet accessibility, limited time to access a PC or mobile phone, and difficulty in matching dates for online interactive training. Solutions: for high transmission, we strict prevent measures and include physical distancing and face masks, less information and knowledge, training central level trainers, frequent update materials for more than from many sources, governmental physical distancing measures. We face this with online training, social media sharing of training materials, quick on-job training, work overload and technical issues, online and offline available pre-recorded videos. Other measures for this is frequent meeting central level trainers for reviewing materials, dividing target groups into small groups for shorter duration, obtaining official license to move freely between governorates and during lockdown. Thank you.
Thank you to you, Dr. Esham. We are really proud, if I can say, to have collaborated to all this training strategy in Egypt with the module of ISS MediLabSecure. And thank you for your very informative presentation. I think that, of course, is also on behalf of Dr. Hannah and Dr. Helen. So thank you also to them.
Thank you.
Stay with us with the second session, but please switch off your microphone. We pass to the second session of the workshop, and because now we have trained our staff, we need to protect them. So we have also in this case 3 countries that will tell us what they are doing to protect their staff. The first expert is from Armenia, is Dr. Romelia Abovian, is the infection prevention control focal point in Armenia. So I think is the most appropriate person to share with us what in Armenia are doing in this field. Dr. Romelia, the floor is yours. You have 7 minutes, and after 6 minutes, I will inform you. Dr. Romelia, are you with us? Dr. Lucine, do you know if Dr. Romelia is with us?
Yes, she is here. I will share the screen now, and she is with us.
Thank you very much. The floor is yours.
Good afternoon, dear colleagues. My name is Romelia Abovian. I'm head of Department of Hospital Acquired Infection in National Center of Disease Control and Prevention, and I am IPC focal point in Armenia. I would like to present you the measures on infection control prevention in hospitals and primary healthcare units in Armenia to prevent COVID transmission and protect healthcare personnel and patients. First of all, I would like to let you know that IPC surveillance system was implemented in Armenia in 2015. Until this year, we had no data for hospital-acquired infection. In 2018, with WHO support was developed IPC program in national level, which involved core components of IPC, injection safety, other interventions like management of medical waste, hand hygiene, medical personnel safety, patient safety, and multifunctional strategies, and so on. By WHO support in 2018 and 2019, an assessment by IPCAT tool was conducted at the national level. Since then, 2019, 119 medical facilities every year were assessed by IPCAT. In the context of COVID, localization and implementation of WHO documents was carried out, for example, of IPC programs, risk assessment of medical staff using the IPC, hand hygiene, environmental disinfection and sterilization of medical equipment, correct laboratory sampling, IPC program of COVID-19 for medical facilities, the usage of PPE. Reprofiled hospitals and hotels, 2 triage hospitals and 8 reprofiled for confirmed patients, plus 5 hotels for mute patients. All IPC requirements have been introduced. Separation of infections, clean zones, trainings about 500 staff members on IPC, hand hygiene, environmental disinfection, correct laboratory sampling. Providing IPC according to the WHO guide based to the signs of the disease. Training more than 1,000 of medical staff in a reprofiled hospital was trained for IPC, hand hygiene, environmental disinfection and sterilization of medical equipment, correct laboratory sampling, IPC program of COVID-19 for medical facilities, and the usage of PPE. At the moment, monitoring is carried out in medical facilities for IPC implementation. Data are analyzed and submitted to the director and to regional bodies for implement IPC in its full volume. PPE, disinfectants for hand hygiene supply, water sanitation, staff training, and so on. At the same time, methodological support is carried out. Guidelines are studied and reviewed if necessary. That is all. Thank you for your attention.
Thank you very much. First of all, to keep the time. Secondly, because it appears that you are very much consolidated in the procedure and what is needed. I mean, in this field for the protection of the health staff. So, as before, we will leave space for the discussion at the end of the presentation. And I will, of course, thank Rumela, and I will ask to stay with us for discussion and to switch off her microphone. Now we have another country to share with us. It's, let's say, it's challenging. We have someone from Mozambique. She's Dr. Emanuela Vivo with Medici con l'Africa QAM, Doctors with Africa. I hope that Emanuela is with us.
Yes, good afternoon. Yes, I am here.
Good afternoon, Emanuela. The floor is yours. Please, you have 6 minutes, and I will inform you when 1 minute is left.
Yes, I am trying to share. I am trying to share the presentation. But I cannot.
Manuela, yes, it's coming.
Okay, thank you.
Your presentation is coming from very far. Are you in Mozambique?
Okay. Okay, wait.
Maybe.
Emanuela, if you press the share and then select your presentation from the share button as share content.
Manuela, do you want us to put for you your presentation?
Yes, I have, yeah. Okay, the presentation is on my screen.
So you have to now to share your screen.
We can still not see your screen, Emanuela, so I will share your presentation myself.
Okay, should be now. Okay.
Okay, so please 6 minutes.
Okay, yes, it's a short presentation.
Okay, thank you.
Yes, my name is Emanuela. I am a medical doctor. I work with QAM, it is an Italian NGO. I cannot go up.
Net zero. Emanuela, what you are seeing in the screen is zero screen.
Okay,
so
it's okay.
Tell her what you have to.
Yes, you can see.
Manuela, we can see. I will be handling your presentation, so just let me know when you need me to change slides.
Okay. Okay, you can change the slide, please.
Can you see the new slides?
Yes.
Okay, please go ahead.
So QAM is an Italian NGO, was founded in 1950 and is focused on health system strengthening at all levels of care, and now is present in 8 African countries. And 1978 QAM started in Mozambique. And in 2004 in Mozambique, there was starting with the collaboration with the Catholic University of Mozambique, Department of Medicine. And QAM in this moment is working in 7 out of 11 provinces in the country. And among the different projects, we are working, personally I'm working with non-communicable disease, diabetes, hypertension, and cervical cancer. And we are working also with the HIV and adolescents and youth, maternal and neonatal health. Okay, next one. Mozambique is a country with 31 million of population, life expectancy 71 years, and maternal mortality rate, just to have give an idea, is 289 for 100,000 live births. Literacy 60.7% of the total population, and an important aspect is the area, the surface of the country, that is 800,000 square kilometers. Okay, the experience that we have as an NGO working part with the Ministry of Health and in part in the provinces was the first when the COVID, the first case was announced in the month of March, was to try to rethink about the project and to readdress the activities for patient tracing, especially the ones with HIV or non-communicable disease. Our support to the ministry was in participation on online clinical working groups twice a week in epidemiological surveillance and case management and the community involvement. The aim of these technical working groups was to understand the situation, to collaborate with the authorities, UN agencies, and other NGOs to develop operational guidelines and to support their implementation at the provincial level. What in concrete was done, as I said, the protocols, tools for monitoring and evaluation. Special attention was given for protective personal equipment, and 26 centers were established and partially equipped in the 11 provinces. Training to the health staff has been organized, and but the problem, what we can see, is now the supervision of these trained staff at the level of the provinces. And then the other difficulties is the declared shortage of equipment, protection equipment. And
sorry, Emanuela, but we should not have go ahead with the slides, no?
Yes, yeah, I went, okay, I went ahead.
Hiro, maybe you can go ahead.
Now you can see. I was waiting for Emanuela to tell me when to change, but it didn't happen.
Sorry. You can change it. Experience during COVID, number 3.
Okay, you have 1 minute, Manuela.
I'm sorry.
Manuela, go ahead, please.
Yes, so with the, as I was saying, now with the last data that we have yesterday, in the country there are 7,100. There were 14 cases and 45 deaths. And in this moment, the numbers of positive cases and deaths has increased, and we can say that Mozambique has not still reached the peak. Most probably, the containment measures worked well. Now, about the health staff, the number is 412 that were infected and corresponds to the 36.6% of the total of health staff that coming from Maputo, Cidade, from the capital. And in the country, 78 of the cases are asymptomatic. To underline that in 6 provinces were carried out sero-epidemiological surveys to understand the magnitude of the outbreak, which categories are affected. One of the difficulties is still the choice of the drug, but then also their availability. Next one, please.
Thank you. We will keep other points for the discussion because otherwise, Manuela, we will be not able to give the space also to the others. Stay with us, please, only muting your microphone. And thank you for your presentation and for raising one issue that so far we didn't mention, the fact that many health professionals are getting infected, especially at the beginning of the epidemic, we may say, at least in the majority of countries. And we know that this was really a concern, not only for them, but also for the, let's say, the system that was in lack, yes, was in need of staff that was instead forced to stay at home. I would continue with Senegal. Our colleague has to say something in relation to the protection of the healthcare staff. I don't know if Christophe or Dr. Barry are still with us.
Yes. Yes. Okay. Then, okay. Hello.
Yes, the floor is yours. Please, in 6 minutes.
Thank you very much. I think we also have to talk about this topic because healthcare workers' infection is also one of another issue in Senegal because we have more than 100 healthcare workers who were infected in Senegal. So for this issue, the government of Senegal used the experiences from the sentinel influenza surveillance in Senegal to handle this problem, and also that make we try to use those people from sentinel surveillance system to help the health workers in all health structure on the appropriate PCI and respiratory hygiene measures, and also to help them from simulation, practical simulation on procedure for dressing and undressing PPA, and also to get a correct completion of the investigation form, and also to make sure that they have the good procedure for collecting, packaging, and transporting samples to make sure that they cannot get infection from their activity. Slide. And also at the beginning of this epidemic, Institute Pasteur of Dakar made the training for 2 international training for SARS-CoV-2 diagnosis, biosafety, and biosecurity for 21 national institutes, hands-on training, and also to give them key distribution and proficiency tests for help them to start to make this analysis in safety activities. And for also that we use the health workers in sentinel surveillance system to go and help the other health workers in all primary health care centers to share experiences with them on good practice filling out form, and also to compliance with the standard precaution measures when using PPA protection procedure for collecting samples that can help them, because they cannot use to cover and to handle this situation before in these activities. And the other thing is, in Senegal, we try also to establish a one network platform that we know is Teranga for all district health workers in Senegal, allowing them to quickly access to the diagnosis, and also to help them to take care about the patient who is positive. And I think that measure will also help to know who is infected, and also to take care of him, and also to make sure that people cannot get infection from that people who is positive to disease. So the last thing is that also Institute Pasteur of Dakar makes one decentralization of the diagnosis in all remote areas, so many measures, many major regions in Senegal. And in that activities, we also made one training for laboratory staff in all regions and districts in classical PCR and gene expert for SARS-CoV-2. And in line to that, we try to put sure that they have biosafety and biosecurity to meet their activity in safety and to not get infection from diseases. So we face some challenges. The challenges we noticed is that some healthcare workers were not very familiar and fear with PPE use at the beginning of this epidemic. And also we noticed that there are some insufficient amount of PPA and sampling tools, so that made IPD try to put some logistic in all Sentinel sites and also some SARI hospital involved in this surveillance to help government to handle these problems. And also we noticed that isolation and social stigmatization of infected patients gives some fear to healthcare workers in the field. And that make that they fear to infecting one love person, and also that makes some limits for them to make activity from people who came to attend in their health structure. And I think we noticed also that there was some risk of reduced attendance at their healthcare facility in terms of consultation that make they afraid, they thinking that if they have this infection that can limit them to make activity on their structure and also to take care about patient who is infected for COVID-19. I thank you very much. If you have some questions, we will be ready to answer you. Hello?
Yes, here we are.
Okay.
There was a problem with the microphone. Thank you very much for two reasons. Of course, for your presentation, because you share with us challenges in your country, but also because you address the problem of protecting also the staff that is working at decentralized level, at community level, not only in our healthcare centers. This is very important and also very challenging in many cases. And the other that you mentioned, very important, is the fact that in some putting all these measures in place, you run in many cases to reduce attendance to your centers. First of all, because maybe the beneficiaries may be scared. And in other case, because you are putting all your resource, attention on the COVID epidemic problematic and all the other access for other health reasons may be hampered, may be put at risk. Thank you very much for, let's say, opening also to these other challenges. Hi, now please stay with us because we are going to have some discussion, and opening the discussion, I would like to see if Dr. Esaiya Meseleh, Senior Advisor at the Director General Ministry of Health of Ethiopia, is with us to report in a few minutes what is the experience of the Ministry of Health Ethiopia in this field. Dr. Meseleh, are you online? Okay, I hope that Dr. Meseleh will be with us in short. Meantime, I would like to know if another lady is with us, because unfortunately we couldn't speak with her so far. Dr. Lazumar, are with us? Are you with us? Are you connected? Okay, while we are waiting for them, I hope to be able to share with them the last, let's say, but not least issues. Dr. Lazumar, are you with us? Can you hear me? Dr. Lazumar, switch on your microphone. Okay, Dr. Lazumar, if we cannot speak today, please send your presentation in a way that we can share with the participants, which is the impact study that Pasteur Institute is carrying out to inform that we are trying to understand which are the risk factors for the health workers in terms of infections at hospital level. So, Dr. Lazumar, we hope to receive your presentation, and now we open to the discussion. I kindly ask Concha and Hiro to tell us if there are questions in the chat or raise the hand. Please.
Yes, it was a comment that wanted to be launched, but some time ago from Christophe MediPIET from Institut Pasteur Dakar. I don't know if it's still pertinent.
Christophe, are you still with us?
Yes, we are with you.
You asked before for a comment. Is still for this session or?
It was in the previous session, but there is a link in this current session because we had an internal discussion, and it is a point, and we say that of course e-learning is really interesting, but there is an absolute need of practical training, how to wear properly PPE, how to behave properly, to sample patients, etc., etc. So there is an absolutely need of a practical, and then it is what performed Dr. Barry when he was on site in the field. In the challenges, we spoke about fear, but it's a reality. So he had to move first fully equipped with the physician and to show them in reality, practically, how it works. So it's more than training people, it's leading them in the field so they are confident with their equipment, and then they lose their fear and they are able to work properly. So that was the comment.
Yes, of course. Without the practical part, all these online trainings are missing something. Another comment?
Yes, Concha speaking from MediPIET team. What Dr. Christophe mentioned is also linked to one important part of protecting mental health of healthcare workers and also the general population, but we are talking about healthcare workers. And in some countries, specific measures were set up in afterwards when the pandemic was already at a higher point and the cases were raising, and the staff was overloaded and had started to have some problems, mental health problems such as post-traumatic stress and so on. So I think that this is something that we always forget about the prevention measures and the protection of healthcare workers, and is a key issue too, from my point of view. I take advantage to say a comment from Isabelle Daoust Maleval in the chat. She was saying that she she fully agrees with Christophe. The issue raised by Christophe, it's a key issue. And we have no further comments for this session from my side. I don't know if Iro has any other hands raised.
No hands from my side. However, people can unmute their microphone if they would like to say something.
We have another comment from Isabel Daoust, but if you want, you can unmute you and participate live. Please, Isabel.
Thank you so much. I just want to highlight and to underline the crucial point raised Christophe regarding the need for practical exercise for PPE. For example, it's important also to train people to objectify the risk of transfer of contaminations thanks to practical case exercise with simulant, for example. And at the end of the day, it's very useful because you can identify all the transfer of contamination that they have to cope in real cases. So practical exercise are really a key issue in order to ensure at the end of the day biosafety for healthcare and for any kind of staff that have to deal with pathogens and so on. Thank you so much. Over.
Other comments or any contributions? Otherwise,
Maria Grazia.
Please.
I think that the National Center of Epidemiology of Carlos III was also trying to intervene. Am I wrong? Maria, Marina, Rosa?
Yes, we are trying to share with you one of our concerns about the how to reach or to get this training for contact tracing Chinese. We are experiencing a bit troubles with how to train these people in charge of making this contact tracing. And we would like to know if any of you in your countries have this experience. Hello? I don't know if you can hear me.
Yes, we hear you, but maybe we are not so skilled in this. I don't know.
Okay.
Now I am referring also to my colleague. Do you know something how they are coping with this problem here in Italy? I don't know. The other countries have similar concerns?
Okay. Très bien noté. Merci.
Yes, go ahead.
Anyone that is trying to say something or to connect?
It seems that there is someone in it.
Yes, I know Dr. Bicaba, but I don't understand if he wants to say something or not.
Hello, everyone.
Yes, hello, Dr. Bicaba. Would you like to say something to intervene?
No, I don't have anything for the moment. But I will join you after.
Okay, we hope that you will follow the other webinar.
Yes.
Yes, thank you. So if no other contributions or message are present, I will go through the closing session. I will start, and then I will leave the floor to Isabelle Noguer and to the MediPIET staff. I really thank you very much to get involved in this workshop. I saw that we were from always from 70 to 100 people, so I hope that you enjoy it. It's really critical to share and to grow on what is happening to all of us. We have not solved this, but we can really take advantage for improving our systems, our service, our ways of doing things, and sharing what is happening in each of our countries. I really thank you, all the speakers, all the contributors, and personally here at ISS, we really thank you, the staff at MediPIET, because it's true that we coordinate the initiative, but without their help, we could have not afford to organize this. So really thank you. And finally, on our side, we would like also to thank Institut Pasteur for the help and the European Union, because it's really transparent to say that as soon as this emergency raised up, the Commission was willing to help us to, let's say, to focus, to change our focus on COVID-19. You know that usually we are working on arbovirus infection, and now with the emergency, we are focusing on it. Thank you very much. See you next time with a new webinar. And please, Isabelle Noguer, the floor is yours.
Sorry, Maria Grazia. Iro wanted also to link with before Isabel's closing.
Yes, I think that you were closing with all the other information, but for me it's the same. If Iro wants to speak before Isabel, it's okay.
Okay, thank you very much. So Iro and then Isabel, thank you so much.
Thank you. I would only like to remind people or to inform people that since April, MediPIET, we've started the MediPIET at Home webinars. So since the 4th of April, we had 7 distinct webinars on COVID-19, from epidemiology to public health action, surveillance, contact tracing, modeling, outbreak response, and risk communication and community engagement. This part of the MediPIET at Home seminars, webinars closed, but the plan is that from October we resume in a second edition, which will be concentrated and focused on the experiences of the national experiences of the different countries in again specific COVID-19 related topics during 1 hour of online sessions. So during this time, participating countries will have the opportunity to share aspects of their preparedness and response strategies and mechanisms, the challenges and the solutions on different pillars of the response. We would like to make this a real discussion. So after the initial presentation, people really to discuss and exchange information, ask questions, get solutions in common problems that we're facing. We have launched a short survey that will take less than 1 minute, where you can fill the survey regarding possible topics that we can touch upon during our COVID-19 webinars. I'm sending the link into the chat box for people who are interested in participating in the survey, and we will be in touch. We will send you the invitations for all of you to participate. So from my side, a big thanks to everybody, and I pass the floor to Isabel Noguer to do the closing.
Hello. Hello. I would like to share only one idea that I think is extremely important about this workshop: the need of building collaboration between microbiologists and epidemiologists, and most generally between healthcare workers and epidemiologists, since only the collaboration between both areas of knowledge gives added value to decision makers and collect population benefits. So I really thank you for this joining workshop, MediLab, for these useful interventions, speakers, and workshop, and to the MediPIET team for contributing to the organization of this excellent event, especially to Concha Martin, key expert, and Iro, scientific coordinator. Thank you very much. I have enjoyed a lot this workshop, and we'll be waiting for all of you for our webinars. Thank you.
Thank you. Bye-bye. Thank you to all. Bye. See you.
Thank you to all, and also to Institut Pasteur and Eva from our team.
Okay, bye-bye.
Bye. See you next time.
Ciao. Thank you.